Next, we'll move to our second innovation showcase, diving into primary care innovations in the employer market. The discussion will be moderated by Dan Mendelson, Chief Executive Officer of Morgan Health, who's chatting with Dr. Michael Willhite with Everside Health and Dr. Amy McKenzie from Blue Cross Blue Shield of Michigan.
It's great to be here. I first want to thank our organizers for including a program on the employer markets. Doesn't always happen. And, when you think about healthcare in the United States, with about 160 million Americans getting their insurance through their employer, we still get relatively less focus on this market relative to Medicare and Medicaid. I think, a lot of that is because the public programs are the focus of government and because there's been so much innovation. But if you think about where accountable care has gone over the last couple of decades, much more focus on Medicare and Medicaid relative to the employer market. So the employer markets are woefully behind, I would say. And when you think about the way that employers have engaged in healthcare over the last decade, I think you have to kind of look at that and say not much has happened. And that's problematic, I would say, for the rest of the system, for consistency, and also for physicians that want to practice consistently across their entire practice to the extent that they want a diverse patient base. So I'll say a little bit about what we're doing at Morgan Health to start, and also in particular how we're thinking about primary care. So we're a group within JP Morgan Chase focused on driving innovation in employer-sponsored healthcare. And there are basically two things that we're doing. One is innovating within our benefit. So we have about 285,000 employees and dependents in the United States. And interestingly, there are some markets where we have a very high concentration of employees. So for example, in Columbus, Ohio, we have 40,000 employees and dependents. And we chose that site to be the site of our first primary care initiative, which I'll say a little bit about. So we're driving innovation in our benefit. And then we're also investing in innovative companies that are really trying to push the envelope with respect to change in employer-sponsored healthcare. So it could be in primary care, as is our portfolio company, Everside Health. We just announced an investment in Kindbody, which is a fertility company that will take full risk for outcomes and cost. We've invested in a lab services company that's moving expensive lab testing from inpatient and outpatient settings into the home. So that's kind of another example. So we've done now 6 transactions in about 2 years to supplement the work that we're doing. And then finally, we have a policy agenda where we're working with partners, including AAFP, I will say, to figure out places where the federal government can really drive the agenda and have a more concerted focus on the employer markets and how to drive accountable care into the employer markets. We're very collaborative in what we are doing. We're committed to bringing our results up into the public. Everything we do is as a minority investor, so we always have investor partners. And then we also work closely with insurance companies and others who are equally committed. So we're not trying to pick a winner really in any respect, in any market, or with respect to any set of services, but we're really advocating for the change. Now, why is primary care important to us? So we believe very fundamentally that primary care is really the key to change and the key to innovation, particularly when you think about things from the employer side. So, when we look at our population, less than half of our employees have a committed primary care relationship. And that's consistent with the national data. That's a problem. We also see particular access issues for subpopulations and for, in particular, populations that are traditionally underserved by race, ethnicity. So that's a major focus of what we're trying to do as well, to make sure that we have primary care resources that are matched into our Black populations, our Hispanic populations, et cetera. So that's kind of a major focus of ours. With respect to digital care, we believe that digital care needs, in particular, digital access to clinicians really needs to be kind of a facet of what it is that our employees can get, particularly our younger employees demand that. With that said, we don't see it in any way as a replacement. So we want to see kind of a digital engagement integrated into everything that we're doing from a demonstration perspective. And I'll say kind of the last thing kind of philosophically for us, and I'll invite Amy and Mike to agree, challenge, counter examples. But the last thing I would say is that we believe in a leverage model, so that primary care can effectively be delivered in a way where there doesn't just have to be one physician. It can really be kind of delivered more effectively, in our view, in a larger leverage practice that is more capable of delivering 24/7, 365 care. And so that's kind of the philosophically where we start. But with that, I'd say that one of the reasons why we love coming to a forum like this is that we're really eager to experiment with a lot of different things, see the different models progress, and see where it takes us with respect to the data. So that's a little bit about our environment. And what I want to do is actually just start and ask Amy and Mike to say a little bit about themselves and why they're here and what they think is interesting, and then we'll get into the discussion from there.
Oh, does take a minute. Sorry about that. I'm Amy McKenzie, and I currently work at Blue Cross Blue Shield of Michigan as Vice President of our Clinical Partnerships area. And when people ask me what is that, it's basically anything to do with our physician network. So we work on our value-based programs, we work on our risk-based programs, and I'll talk about that in just a minute. I am a family physician by training, very passionate about primary care. I chose primary care because I enjoyed the concept of caring for people from birth to death. And I, see the value in the relationships that are created. And I believe strongly that that is how we can help heal people. And so, with regards to, what we're doing, we have been, for the last 20 years, working to expand care that's being paid for rather than just on a fee-for-service basis, tying that to value. And we feel very strongly that it's important that we partner with our physician community and have been doing that for the last 20 years in different ways, both on the primary care side as well as on the specialty side. And that has enabled our success as we've continued to move the payment models forward because we've invested in infrastructure, things along the lines of building out registries, the ability for these practices to be able to track their patients. And we do that at scale because we're working with large, whether you call them IPAs, we call them physician organizations in Michigan. It does tend to be a unique model. We have 40 physician organizations across the state that represent their physicians, whether they be primary care or specialists, for these value-based arrangements, as well as providing the data that is needed. And so as we've continued to evolve those models and developing out that infrastructure, some of which is care models, some of which is technology, some of which is health information exchange, we have gradually moved the community along to be able to start stepping into then taking limited risk on the commercial side and then gradually moving to full risk contracts on the Medicare side. So it's a very rewarding role that my team gets to play. We feel like, the partnership with the physician community is a critical piece of that secret sauce. I think all of us know that if you're not at the table in helping to create those models, things are not going to move forward very well. And so we engage with our physicians across the state to help build these various different structures out, whether it be, we're advancing patient-centered medical home or team-based care or collaborative care. So that's a little bit about what I do.
Maybe I'll throw one question your way. Say a little bit more about the relationships with the primary care practices. Like, what incents them to want to work with you? And what are the good things and the more difficult things about those relationships?
Yeah. So with primary care, in terms of the incentives to work with us, part of being part of our network is that we felt that if we didn't create some structure for development of quality and infrastructure, nobody had it, right? Nobody had the dollars to be able to provide. And so part of that is that a portion of what their fee-for-service payment is gets allocated into a fund that helps to support quality improvement. And that goes all back out to the provider community, but we co-create on what that's going to look like with those leaders and medical directors from the provider care organizations across the state. Obviously, we can't have every practice at the table, but we have medical director leaders at every physician organization that are participating with us. And we run a primary care leadership council, for example, that meets quarterly to help set our direction. There are also incentives tied to their participation, but also their how they're performing. There's significant dollars for primary care, and we've continued to invest in that space. I think we heard from the panels earlier, and I would agree, primary care has heavily been underfunded in our country. And so we are looking for ways to be able to advance that, tied to performance, whether that be I'm measuring you on your HEDIS performance, right? So very direct quality performance, your cost of care, but also things like if you're deploying a care model that we know requires resources and requires time and commitment for your staff and is going to benefit our members, we're going to pay you more to do that. We're also going to come alongside you and provide the resources to be able to help train and get your staff up to speed, get your practice up to speed to be able to move in that direction.
Take it away, Mike.
So thank you. I appreciate the privilege and honor of being here and discussing these important topics. But I'm Mike Willhite, and I was born, raised, educated, trained, continue to work all in the great state of Indiana. And my first 20 years of professional life was spent in traditional fee-for-service primary care. I was in small town Indiana, and I was employed by the local health system. And by the end of those 20 years, the challenges that we've all been discussing were becoming a bit insurmountable. In fact, I was finding it difficult to be faithful both at home and at work, and something had to give. And so along came Deb Geisler, who was one of the principal founders of Activate Health, direct primary care company. And, a lot of praying and decision making, but made the leap of faith and started to work for Activate in direct primary care, and soon was wondering, is this too good to be true, and waiting for somebody to pull the rug out from under me, but it never happened. And in fact, I was enjoying it so much that they gave me some leadership responsibilities and wanted me to help scale up what they were doing. And so now Activate's a part of Everside Health. So, and Everside is a growing organization. So we're 34 states, 140 different markets, and close to 400 health centers, taking care of 1.6 million lives. And it's a real privilege to be a part of this. And so the last couple of years, then I have been more specifically dedicated to one client, which is Eisen. It's a manufacturing company of automotive parts. And so right now I'm giving oversight to the health centers that are taking care of all of their employees. And right now we have 4 health centers: Indiana, Michigan, Illinois, and Kentucky. And they put a lot of confidence and trust in us and working with us to supply the care that they need. And again, I think that it offers a great framework to address all the disparities and inequities and the challenges that we've been discussing this morning. So, but I'll leave it at that.
Great. So maybe we could start the conversation by talking about employers and your interactions with employers, the level of knowledge that they have. Are they thinking about primary care as a solution to the discontinuities of care, or not? And some candid thoughts. And Mike, maybe we'll start with you. I mean, you see probably a range of different approaches, and would be interested in maybe starting with that.
Yeah, I think there's a spectrum of understanding that employers have when it comes to knowing what they need. But I think that they're starting to understand the significance and the role that primary care plays in providing that benefit for their people. I think that they see that if they can partner with a direct primary care company, they see that as a benefit to their employees in terms of retaining them and keeping them healthy and keeping them at work. And so I think that sort of vibe is contagious. And I know our client at Eisen has certainly embraced that. But yeah, I think there's a spectrum of understanding. And so,
how do you think from the Everside perspective in care navigation? So one thing to have, a relationship with a primary care practice, another thing to be able for the patient to be able to then navigate through to other resources in the environment. How do you think about that?
Ask that again. I'm sorry.
Well, I think one of the things that employers, I'll give a little more texture to it. One of the things that employers think about or maybe struggle with respect to direct primary care is that, you can have confidence in the primary care services, but then how does that patient then engage in when they get cancer or when they have a heart condition or when there's something rare that comes up, what happens at that point and how do you deal with that?
Yeah, so I guess it all starts with the first program that we initiated was just a wellness program. And so the employees are incentivized to actually take time off of work, which is compensated. They come in, they spend an hour with our providers, and that's our opportunity to get to know the patient and to really foster that relationship and become what we would consider their trusted advisors. So we really want to invest in the people and get them to know us. They have easier access to get to know our providers. So I think by the time that something catastrophic happens, I think that we have built that relationship and they have that confidence in us to guide them and help them to navigate.
Amy, you could take anything that we've done so far. Maybe start with you see employers are like one aspect of everything in your universe.
Yeah. So I can attest to that our employer groups are quite interested in moving, care along the value-based continuum, first of all. And we're seeing an increasing number of asks for conversations of, well, we understand that you're moving to full risk and Medicare. Like, how do we start thinking about moving further down that value continuum in terms of payment on the commercial side? And there are some challenges there. But you also asked about their interest in primary care. We absolutely do see that, particularly from some of our more progressive employer groups, an interest in these concepts around advanced primary care, which can be defined differently based upon who you're talking to. But for us, it's really these team-based care concepts of, you're no longer just the doctor practicing with a medical assistant. You now have a social worker in your office. The medical assistant's certainly part of that, but maybe community health workers or a pharmacist, basically allowing that additional expertise can help with both coordinating care for that patient, but then also ensure that everybody's working at the top of their license, that we don't have, the nurse calling and sitting on hold, trying to get the patient coordinated, to an office visit. So, but it's also integrated behavioral health. I think that there's a real realization. I heard somebody say earlier when they were practicing, about 50% of their patients in their office had mental health conditions. I can say from the time period that I practiced as well, that's pretty consistent. I mean, it's very significant in what you see in primary care. And with the mental health crisis that we have in our country, we also know there's stigma associated with mental health. I think making that, ensuring that you have those resources embedded in a way that can care for the patient and look at the patient holistically, right? If you have diabetes or if you're going through a cancer diagnosis, we know that it's very likely that you also may be struggling with depression, right? And we should be treating all of those things because you're not going to do as well. You're not going to be as activated as a patient if you're depressed. You're not going to be taking your medications or doing the lifestyle changes that we need you to do associated with that chronic condition. So they are very interested in the advanced primary care concepts. And then I think the other question was on the care navigation piece. Yeah. Okay. We do see interest in that as well. I will say that seems to be kind of a secondary piece for us not that it's not important, it's very important because I think there's a recognition that where people get their care is critically important, especially when they start into that specialty area, because the practice can vary widely and the costs can vary widely. I think there's a lot of tools out there that employers, what we are hearing, a lot of tools that employers have deployed to help assist their employees with probably variable adoption, right? When you put those tools in the hands of a patient, they may be used, they may not be used. People might get confused. I think increasingly what we're hearing in the conversations that we're hearing is, hey, we recognize that primary care has a significant role here and that when the patient's attached to a primary care physician and they're the ones who maybe now are using these tools to figure out where the best place is to send people, that there's a trusted recommendation and that people are more likely to follow through with that instead of bounce around the system. Yeah. So that's kind of what we're starting to hear.
It's you said so many things that are descriptive of some of the pilots that we're doing. So I'll maybe fill in a little bit of the blanks on where we are. So what we're doing in Columbus, we have a PreHealth as our partner, but the primary care practice is a wonderful primary care practice in Central Ohio called Central Ohio Primary Care, COPC, that some of you might know. And they've been a great partner to us really since the beginning. And so what we did was first took our on-site and near-site clinics and asked a PRE to come in and operate those jointly with Central Ohio Primary Care. And COPC, interestingly, about half of our employees who have a committed primary care relationship already have one with COPC. And it's not mandatory. I mean, it's completely optional for the employee. But if you go in to the clinic to get a COVID shot or a flu shot, or because you got a paper cut, you're going to be offered a primary care relationship. And so people come out with that. You're also offered a mental health evaluation. And it's really kind of a way to say that we really are caring for all aspects of our employees, and we want to see them kind of be invited into the system. So then they can either go to COPC, they can stay with their existing primary care physician, it's fine, but we want them to have primary care. So driving the percentage of employees with a committed primary care relationship is a really central goal of ours that we carry and we monitor. And then with respect to, you said a couple of things about the care navigation that are spot on in our environment. So one is that like we have a bunch of different care navigation systems that are operating in our environment. Some of them are the commercial care navigation systems, and even just helping the employees understand that these systems exist is a challenge because you get a ton of emails and it's like, hey, you can access through included health, but they don't know what included health is and they don't understand really the services that can be offered. But what we're finding is that with a pre-pilot with Central Ohio Primary Care, they listen, because if they have a primary care physician who is encouraging them to go to one or another specialty group or a particular specialist that has been associated with better quality and lower costs, they will do it. And they don't have to be financially incented to do it, by the way. But if their physician says, look, it's time for a colonoscopy and here's where I think you should go and this is why, that tends to be very effective. And I'm curious whether you see the same thing.
Yeah, I think that, what we've seen in the employer market, and probably at times to the frustration of some of our primary care physicians, to be honest, is this huge explosion. And it's not just in our employer market, it's everywhere. It's on our Medicare side too, of these vended solutions and digital solutions to be able to help step in and help people understand their healthcare better, help navigate better, provide care resources. But for physicians, at times it can feel disruptive because they don't necessarily understand it, nor do they know which tools go to which employer groups. And it can feel, but I think that what you're getting at is very much what the secret sauce can be, is how do we partner and bring those solutions together with our physicians? Because when they understand them, what we've learned is that they're like, oh, this isn't trying to replace me. This could actually augment what I'm doing. And I could utilize that. And I do believe that the adoption to exactly what you're saying, we've heard the same things, that I think to the employer's frustration is those tools can get underutilized because patients don't necessarily understand that. But when you start to connect those things, I think it can be quite powerful.
Yeah, I was just going to add, if I may. So our current health centers are in smaller, more rural markets. And so one of the things we're doing now is trying to approach those local health systems and create and develop some local partnerships for care navigation. And I think that instills a level of trust amongst the patients as well, that they can stay local and have those opportunities. So.
Love to hear more. So you're operating in these rural areas. I'd maybe like to bring the conversation into a discussion about what is the optimal configuration of a primary care practice for the benefit of the patient. And I said a little bit about this idea that we like a leverage model, particularly if it's able to deliver 24/7, 365 engagement, keep patients out of the emergency room. As opposed to a more traditional model where it might be difficult to access clinical services after hours. What does that look like in the Everside world?
Yeah, so we have 24/7 care, and I think we have been successful in keeping our patients out of the ER and the urgent care center. And again, they've come to trust us, embrace us as that trusted advisor. I think they do respect the position that we've taken. And so I think we've been able to give them helpful guidance to navigate them on a higher quality, lower cost trajectory through those local partnerships that we've developed.
Do you measure and report back to the employer or someone else, like how you're doing with respect to?
Oh yeah, we're constantly tracking all of those measures, including clinical quality measures and the such. And so I guess one concrete example of that, we had a low colorectal cancer screening for that particular population, and so we were able to contract with one of the vendors and send fecal based kits to their home for all those people that were non-adherent, and so it really increased the colorectal cancer screening rates. And so it's things like that we're able to accomplish.
And then how much of the primary care are you doing on site? So like one of the things that we are experimenting with right now is on-site mammography, because particularly in certain populations, the mammogram rates were really low. So we bring a truck to the facility and just try to.
Yeah, we're investigating the mobile mammography as well. So yeah, I think that's highly successful. It's just a matter of finding those opportunities.
Interesting. Amy?
Yeah, I would say we've done those types of solutions as well, direct to member, or we're even getting into some of the screenings for earlier detection of CKD. Which is heavily underdiagnosed today. We are particularly trying to stratify populations or get into geographies where we know it may be difficult for people to get care because of social barriers or social determinants. So when we look at when we bring in like a mobile bus or mammography, we do it in particular geographic areas that we know can be a challenge, or where we have lower rates, screening rates otherwise.
Do you engage with employers and try to get them to drive patients into cancer screening?
Yeah, we have provided notifications as well to employer
groups. Does
it work?
Honest.
I mean, it is variable. I will say, some of what I've heard, and I was just out at an employer group talking about some of this the other week, is that, there are some trust issues at times when things are directly pushed from the employer group or from the health plan of like, why do you want this? And, particularly in the populations that we tend to see that are under-screened, they have a higher propensity for just not trusting the overall healthcare system. And so that is where I think these primary care models are so critically important, because I do believe that there's a greater trust in that personal relationship that you have with your physician than when we're doing the direct outreach from the health plan.
It's really fun. I'll kind of one thing I find amusing about this. So number of times I've been asked to go out to Columbus to talk about, our plan and advanced primary care and that kind of thing. And I'm always rejecting those requests. I was like, you've got a whole group of fantastic primary care physicians in COPC, and they have a lot more credibility than some guy named Dan Mendelson, so get a doctor out there to talk to them, because it's really the way to build the trust among the community, which I think has been going up by virtue of the fact that I've been hiding,
Yeah, I agree. I think the challenge, though, is at the same time, we're also seeing greater numbers that are not attributed to a primary care physician because they're looking for more flexible models or more convenient models. And so I think that that's where we've lagged a little bit. I do see people starting to catch up, and I think COVID pushed us there to a certain extent. But
strengths and weaknesses of digital engagement and how you integrate that into your practice. Mike, you want to start?
Oh yeah, it is a challenge. We do have some digital outreach, but not everybody has access to the portal, and so that's a challenge. We send as much stuff as we can to the client to push out through their screens and everything they have within their reach. But yeah, it is a challenge. I was going to say as well, moving from traditional primary care to the direct primary care, it's interesting how in primary care everybody just came to me, but it was with those urgent needs. But now I'm thinking that population health thing, and so I'm trying to cast this broader net. So that's where the data comes in and evaluating that. And so we do a ton of outreach that way. We look at claims data and we look at the information through the health information exchanges, and we put it through some search engines. We use ACG modeling, but by virtue of those things, we can pursue this crowd in a way. And again, we can do that digitally. We put that through the portal as well. And we have patient journeys depending on what particular issues they're dealing with. But that it's a great way of getting them in as well.
How much targeted outreach can you feasibly do? So you probably know who's had cancer screenings and who hasn't. You probably know certain things. But I'm interested in what the level of effort is around that versus being responsive.
Yeah. So, that's number one. That the cancer ones are the easiest. I guess some of the more responsive ones things. I think we are looking at A1Cs and blood pressures and looking at those. And so that's a monthly thing that we're outreaching to those folks.
So like standard population metrics, essentially. How about with respect to maternity?
That I can't speak to be honest with you.
It's interesting from my perspective as an employer. We haven't solved this yet, but I can tell you that if you look at zip code, you can predict the probability of an unnecessary C-section pretty accurately, and it's really problematic. And I look at that from an employer standpoint that we are paying both insurance companies and providers to produce that result for us. And that's not right, And so this question of how can we engage? Should we, as an employer, be proactively calling people who are pregnant in those zip codes up and say, hey, you're high risk by virtue of where you live. We want to get you into appropriate care. And this is or should, can we be relying on somebody else to do that for us? So that's something we're thinking about.
Yeah, that's a challenge.
Yeah. You have a touchy subject.
It is a touchy subject. We've seen the same types of things in our data, and we actually stood up. I mentioned that we've had these kind of large collaborative. We actually stood up one of our collaborative quality initiatives around obstetrics to try to get at this. It is a very touchy and challenging topic. We've actually folded in some additional metrics around maternal morbidity, mortality, not just C-sections, because there's a lot of work that needs to be done in that space. There's a ton of disparities, and it's multifactorial.
Do you see mortality issues in the employer markets, or is it more Medicaid and
Yeah, certainly we see it in the employer markets, but I will say that the data is definitely more skewed on the Medicaid side.
On Medicaid side. So we don't see a lot of maternal mortality in our plan, thankfully, but the C-section rates and other kind of fetal distress, other metrics, very problematic, and that's definitely something that we're focused on. We did an investment in a fertility company, Kindbody, that we're excited about, and they're starting to kind of diversify into broader women's health and maternity care as well, and so that's something that we're thinking about a lot. But even just being able to notice women who are pregnant in those geographies is something that, and some employers do this, and we have one employer that we're working with right now who essentially will give a financial incentive to use a certain provider practice in a geography because they're associated with better outcomes, and they've convinced themselves at least that they will save money if their employees use that practice versus other resources in the area. I'm curious, you have a lot of resources at your disposal in Michigan. Could you do the same thing?
There are challenges in doing that. When the focus that we have taken in Michigan is, I think that's getting into should we be steering? There certainly, I know, is some interest in that. We also do value, however, quality improvement, right, overall as a community. And so we've invested in these kind of large learning collaboratives where they capture data, put them in registries, especially specialty care. There's very limited amount that you can learn from just claims data. Claims were set up to pay physicians, right? They were not set up to necessarily gather information about quality and drive those quality improvements. So we actually invest in these collaboratives to go out and look at the very rich data that is involved in medical records and then line that up against outcomes. Because generally when you're seeing a poor outcome or it's a system-based issue. It's usually not a individual, and that goes back, years. Institute of Medicine's looked at this, and it's usually a whole system of things. And so, to me, it is about building better processes of care, identifying what processes drive those better improvements. Collaborative care is one that we know of, right? Team-based care is another one, and there are several in the surgical space as well. Whether you have, obstetricians that are there 24/7, similar to hospital intensivists, right? Maybe one of the things. So it's about identifying what those systems are to improve and drive toward the quality and the care that we need.
Maybe we can, we're going to open it up to questions in about 9 minutes. So think about anything that you might want to address the panel, and no questions are off limits. We can even talk about the benefits and detriments of steerage further, which is, it's a very interesting question, from our perspective, just because, there's a question about like, are the practices actually improving? So it's like, okay, that's nice. But then if they're resistant to change, is there a point where they should really just be kicked off the network? And like, we shouldn't be paying anymore for those types of outcomes, but I'll let that one lie for, for a little bit, because you're so thoughtful on these things. But, maybe we could talk a little bit about kind of the ideal of what you would like to see in order to further your model. In other words, you've got these employer markets, and and Amy, I think you said it well, that employers are not necessarily focused on care models and all these other kinds of things. They're trying to run their business, and so they're probably not as sophisticated of a purchaser as, for example, CMS or a state, that is going to come in and like drive you to a certain model. But the question I want to maybe wrap with is what would you like to see happen that would facilitate a more rapid expansion of value-based care and improvement in employer markets, either, from primary care practices or from other actors in the healthcare system?
Let me make sure I've understood that. Like, what types of things would I like to see in the environment to allow for that expansion in kind of value-based care on the employer market side?
Exactly.
Okay.
Well, better put than I did. So thank you for that.
Well, let me start with the challenges, because I'm not sure that I fully have all the solutions. I mean, there are a couple of things I could spit out that, I'd like to see better adoption of health information exchange nationally, right? We have a pretty good statewide health information exchange. I'd like to see, better EMR integration, right? Like those types of things. I think those are really big things that we as a country need to do. I think that some of the challenges in the employer market with continuing to expand into value-based is, what are the right models to develop for payment purposes? Because we've looked at reconciliation at the end of the year, right? Like when you go into full risk and that kind of shared accountability, you can get into like, well, now this is what is owed at the end of the year, whether on the provider side or on the employer group side. How do you reconcile that? And how does an employer handle that, right, in their budgeting, right? I think is a real challenge. It's one that we've run into. And so thinking through what those payment models should look like, and it's going to be conducive for everybody. It's not going to break the provider on one side, and it's going to be conducive for what the employers need for their purposes of understanding budgeting going forward. I also think the other challenge that we see is this engagement, this kind of lower attribution with primary care is a challenge in what those benefit structures should look like, as well as what should the plans look like. Many of our employer groups want to offer not just an HMO, but also a PPO, right? People want broad choice. And I think our employer groups prize also having these broad benefits and rich benefits, because that's how you attract and retain employees. The challenge there is that as you move along the value-based continuum into taking on more and more risk on the physician side, what you want is you want to be able to control what's going on with that patient, which is more akin to an HMO model than a PPO model, right? The patient is attached to the primary care physician. They need referrals. That primary care physician's able to control that care a little bit better. So it gets into like a lot of the tools that are needed, as well as the alignment of the benefit structure to encourage members to do things in a way that is aligned with what the physicians want to do. Because if we want to preserve the ability to have kind of this broader based network in the benefit design, we have to somehow have some structure that the physician can work with and doesn't feel like they're getting penalized. Well, patients just going everywhere and I can't control them anyways. And now you want me to take full risk on them. Those two things don't line up very well. So I think we have a lot of those things to solve around, right? And we're only going to do it collectively by having the health plan, the employer group, and the provider at the table to be able to do it. Yeah. I don't know if that's the answer you were looking for, but
it's incredibly thoughtful, and I agree with it. Like there are a couple of things that you said that are really core to our agenda. So on the health information exchange, that is probably our number one policy issue that we are advocating for, is to figure out ways that the federal government can facilitate, more effective and secure, by the way, data transfer so that we can get more information and address a lot of these issues. And that's very related, I think, to the latter part where you were talking about, kind of the importance of being able to engage and steer. Because I think, from what we see in our pilots, a lot of it is about trust with the patient. And you don't need to control them. You need to have a trust relationship and actually help to guide them, and they will believe they want to engage with their primary care practice and their physician. They want to be steered and guided.
I fully agree that all of this is going to move at the pace of trust. We've talked a lot about, little bit about social determinants as well. And I know there were discussions about that earlier and even capturing that information. There's so much sensitivity around your own personal health information alone. And then when you start talking about, well, I can't afford food or I can't afford transportation, that feels very personal to people.
Right.
And so, that's only going to be built on the trust and that trusting relationship that they have with their physician.
Another anecdote I'll tell you about these care navigation systems is a dear friend of mine whose company has, again, a sample of one, but I think it's interesting, called up the care navigation company and was transferred to some kind of a hotline that was not in the United States, and she hung up. And she's like, I'm not gonna listen to this. But if her primary care physician had said, really, what you should be doing is that, it would have been a very different kind of situation. Mike, what do you want to put on your wish list of things that you'd like to see change?
Yeah, again, just thinking about direct primary care solution in the employer market, I see it as the great equalizer. Again, all the challenges that we've discussed, I think it provides for a true egalitarian system when it comes to providing medical care. So I think that everybody in the employer space should be taking full advantage of the direct primary care opportunities. I think that if there's legislation out there that gives tax benefits, maybe to pursue these sorts of avenues, I think that would be helpful. But again, having come from the traditional healthcare to this particular model, it's been liberating for me, and I think it's not necessarily the solution to all of our healthcare issues, but I think it's definitely a helpful step in the employer market. So,
let's open it up to questions or comments from the audience. We've got about 15 minutes left if we want to use it, and we'll see what's on all of your minds. Yeah, please.
Hi, I'm Kenneth. I'm a direct primary care physician. I also explore primary care larger at PrimaryCare.com. But one of the things I've been thinking about is time horizon. So the average employee will stay with the company for about 4 years, with a health plan for about 2 years. But some of the things that we do in primary care kind of affect them 20 years down the line. So how do you best express to an employer that you should get this high value thing that might benefit a patient in a way that they might not see the benefits of, right? When the patient is long gone and doing better. How do you reconcile those two time frames?
So I can start, because we're an employer and we're grappling with this very thing. I'll say, kind of at the outset that we have much better longevity at JP Morgan Chase than you see kind of in the market as a whole, because employees tend to stay for a longer period of time. But if you look at lower wage employees, the turnover is significant. We have data centers, call centers, and the like. And while we don't do a lot of kind of gig economy pay as you go. Most employees are on, kind of on a full-time basis. You do see more turnover in that area. And I'll say that that when we look at the benefit, we are focused on population health, and we want to see improvements in population health on the belief that they will improve matters for the company over an extended period of time. So it becomes kind of philosophical, but I've seen kind of in prior lives as well as kind of in other engagement that there are a lot of questions that will come up about things like insulin pumps and other technologies that are clearly critical for the life and welfare of a patient, that employers will sometimes kind of be a little bit more reluctant if they think that particularly a capital technology is going to kind of walk out the door. And I think we have to push back on that. So I don't have like a really good answer to how do you convince the employer that the short term is not the most important thing, but I do think that you will find many employers thinking more holistically about it. I don't know, Amy, you probably hear the same thing.
I do. And of course, you asked like the toughest question. I mean, churn is, it's real. I think it depends on the employer group. Some have more longevity. And I think those conversations are easier when you have a lot of churn and a lot of turnover. It is hard to make the conversation around those investments. We actually, as we looked at some of our strategies around investment around social determinants on the commercial side, that was exactly what came up. I do think that as a country, though, and as physicians and physician leaders, we have to start making the case of, yes, we understand that, but if nobody ever invests, we are going to continue to see these escalating costs. And they know that at this point. And I think people are bought into that concept. So I think the tide is starting to change. Many of these investments, we've even seen it, at Blue Cross. We had a program around team-based care. We knew in the literature that it bore out value. Same for diabetes prevention programs. But when we implement them, it takes us a number of years. And I and other physician leaders have had to stand up with our business units and say, we are not ready to take this down. We need more time. We need more scale. And we actually were able to bear it out, but it took that investment of 5-6 years and then a longitudinal analysis. And then we got to a 2.2% total cost of care savings on a team-based care model. And if we don't allow those things to play out, we're going to continue as a country to see these healthcare costs just continue to escalate, because when you're just throwing Band-Aids on things, we're not getting there. And I think people recognize that at this point.
There's one other aspect of this that I think is important, particularly for AAFP and other organizations that are thinking about this, which is that if you respect your employees and you provide them a higher level of care, they're going to be less likely to leave. And it's interesting because like in our philosophy, in the kind of the Morgan Health philosophy, we want all of the tools and technologies that we develop to be available broadly in the marketplace. So any employer in Columbus that wants to avail themselves of the model that we're developing through a PRI is welcome to contract with them to use it. Okay. However, it's interesting because there are some senior people in the bank who've come to us and said, why don't we keep this for ourselves? Like, we're providing this incredibly unique and valuable service to the employees. And I do think that we need more research on how kind of a deep level of primary care engagement might actually extend employee longevity, because it's very expensive to replace employees. And I'd love to see more analytic work around that. And we're going to be doing some analytic work around that to see if we can correlate, outstanding leverage primary care with employee longevity. So that might be part answer to the question.
If I could just also add that I just love your question, because I think it's coming front and center too with like what we're seeing come down the pipe with the GLP-1 meds, right? And obesity. We all know, name a disease out there that obesity doesn't create increases, right? From cancer to diabetes to hypertension to cardiovascular, everything gets worse with obesity, right? But these investments are going to be really big. And how are we going to handle those for, when we have employer turnover, I think that it's challenging, but I think that increasingly we're seeing employer groups start to recognize that they need to drive upstream of the end consequence, right, of some of these things. So,
Mike, you want to add anything here?
Yeah, again, I'll brag on ICE, and they've invested a lot of trust in our organization, and So I think they just want to do the right thing. I mean, so right now we're talking about mental health services, and there's not immediate ROI on that, or at least that we can demonstrate. But I think they're really committed to doing what's best and right for the patient. And even if they don't reap the long-term consequences of that, I think that if, somebody's got to lead in that direction. So, I'm excited about that. I think most employers will follow suit once they see the value in that.
We have time for another question if anyone wants to get one in.
Yeah. Really quickly, and this is probably more for Dan than anybody else, but I think when we think about trends in sort of this part of the segment of the market, what are we learning from past stumbles? So for JP Morgan, right? The Haven experiment to now, obviously a lot of the challenges are still the same, but going through that experience, and for all three of you, what's becoming the core lesson?
Yeah, I mean, I think that the Haven experience was difficult because you had three really different companies, Amazon, Berkshire Hathaway, and JP Morgan, each of which wanted something very different out of the partnership. So, Atul Gawande is a wonderful human being and a brilliant guy, but I don't think anyone would be smart enough to overcome the governance challenges that he had from the get-go, where he had these three companies and what did Amazon wants revenues from the consumer channel, JP Morgan wanted a better benefit. Berkshire was actually really interested in reducing drug costs, and the three of them couldn't agree on what they wanted to do, and it was problematic, and I think the thing that JP Morgan learned was keep governance super simple, retool, figure out what's important and drive towards those important things. I'll say kind of with respect to the broader point about, kind of what do we learn from kind of where are we strategically right now? Costs are going up dramatically. You mentioned the GLP-1s, amazing technology that's going to drive costs more. Cell and gene therapy will drive costs more. I mean, I think we're getting towards a breaking point, and the reason why Amy, you see from employers, and Mike, your model exists. It's we have to get our arms around quality, cost, and health equity at the same time. And I think employers are increasingly realizing that and will be increasingly unwilling to fund healthcare that does not meaningfully address those three things. So I really do believe it's a great time to be focusing on the employer markets, because a lot of the change that you saw happening in Medicare and Medicaid over the last decade are now kind of coming front and center into the employer markets. And so, it's I listened to Amy, and I will say I have not heard a better health plan executive on these issues. And it's I want to move our employees to Michigan so that we can avail ourselves of the wisdom. But, it's that's what we need. We need that kind of thinking to drive the system towards more accountability. So I don't know, Mike, you want that one?
I don't know that I have anything to add to that. Thank you.
And Amy, you wanna, or we would have time for one more question if somebody wants to get one more in, if you want to go that direction. All right, Amy, then why don't you respond? What do you think the challenges are, and where do we go from here? And you can have the last word.
I mean, the challenges are the escalating cost, right? It's just, when you look at the numbers, I whenever I talk on this topic, I say, I worry about my grandkids being able to, my kids even, be able to afford health insurance, right, for all of us. And we also have, we didn't even get into, but some of the other groups, I was here a little earlier, talking about the demands on primary care, right? Not enough reimbursement. There's supply challenges with primary care. There's supply challenges with, staffing in primary care offices. I do think the way forward, I think value-based care and shared accountability, and what that means, you will hear some people at our plan say, well, we have to go to full risk. We have to go to full risk. I'm like, well, I'm not sure if it requires full risk. It requires the attention of the providers. I tell people too, when my kids come to me, who are just kind of in that phase of launching, right? So they have some of their own money, but use a lot of my money. When it's my money, they don't really care what the bill is until it's their own money that they're digging in their pocket and they care. And that's the same type of thing we're trying to incent, as we we partner in these value-based care models. We want enough attention on this and awareness and care at the practice level to ensure that people are making decisions that also think about affordability. For a long time, as physicians, we really think about quality and what we want to do for our patients. And those things do align, but it's finding that sweet spot. So I don't know if I have the best answer in terms of where we need to go, but I do strongly believe that value-based care models will create a better future and better payment models for primary care. I think we need to get there on the commercial side. I think there's a lot of challenges that we've talked a little bit about today in getting there, but I think we can do it if we are all at the table.
Great. Amy, Mike, thank you very much. Please join me in thanking the two of them for
Thank you.
this conversation.